Hi friends, welcome back to my YouTube channel. So first of all, please subscribe to my YouTube channel. Then coming back to our today's topic is cardiomyopathy. Its important types. There are three types. Now its causes, nursing management, diagnosis, and its symptoms. So let's start the video. Cardiomyopathy, disease of the heart muscles in which heart loses its ability to pump blood effectively. The heart muscles become enlarged, are abnormally thick or rigid. In rare cases, the muscle tissue in the heart is replaced with scar tissue. तो कार्डियोमायोपैथी क्या होता है? ये एक हार्ट मसल की डिजीज़ है जिसमें क्या होता है कि हार्ट मसल्स वीक हो जाते हैं, वो अपनी एबिलिटी लूज़ कर देते हैं टू पम्प ब्लड इफेक्टिवली, जिससे वो क्या करते हैं बम्प ब्लड करते हैं इफेक्टिवली, लेकिन वो नहीं होते। उसकी वजह से क्या हो जाते हैं कि मसल्स इनलार्ज हो जाते हैं या थिक या सख्त हो जाते हैं, रिजिड हो जाते हैं। और फिर रेयर केसेस में क्या होता है कि उन्हीं टिश्यूज़ को हम रिप्लेस कर देते हैं स्कार टिश्यूज से। नाउ व्हाट आर द क्लासिफिकेशन? सो देयर आर थ्री मेन टाइप्स ऑफ कार्डियोमायोपैथी आर dilated cardiomyopathy, number 2 hypertrophic cardiomyopathy, number 3 restricted cardiomyopathy. Number 1 dilated cardiomyopathy, a condition in which heart muscles ability to pump blood is decreased because the heart main pumping chamber, the left ventricle, is enlarged or weakened. Most common form of cardiomyopathy generally occur in adult 20 to 60 age, more common in men. Dilated cardiomyopathy can affect organ systems such as lungs or liver. Pathophysiology of dilated cardiomyopathy: diffuse inflammation and rapid degeneration of myocardium, ventricular dilation, impairment of systolic function, impaired emptying of left ventricle, left atrial enlargement, and stasis of blood into the left ventricle causes cardiomegaly. Moving towards the causes of dilated cardiomyopathy. Number 1, cardiotoxic agents like alcohol, cocaine, genetics, hypertension, ischemia, coronary artery disease, CAD, muscular dystrophy, weakening and wasting of muscles, myocarditis, in which we see the inflammation of myocardium, valvular disease. Now moving towards its feature of dilated cardiomyopathy. Number 1, decreased exercise capacity, fatigue, dyspnea, paroxysmal nocturnal dyspnea, orthopnea as the disease progresses, dry cough, palpitations, abdominal bloating, nausea, vomiting, anorexia. So these are the clinical features of dilated cardiomyopathy. Some more features of cardiomyopathy are abnormal S3 and S4 sound, tachycardia, bradycardia, edema, pulmonary crackles, weak peripheral pulses, jugular venous distension. Now, what are the diagnosis tests of dilated cardiomyopathy? Number 1, we're taking the history. Number 2, echocardiography. Number 3, chest X-ray shows the sign of cardiomegaly. ECG reveals tachycardia, bradycardia, or dysarrhythmias. Cardiac catheterization, it is performed to confirm the coronary artery disease, which is CAD. So here is the diagram of femoral vein in heart and catheter. Now, what are the medical management? Number 1, nitrates, loop diuretics, ACE inhibitors, beta adrenergics blockers, aldosterone agonists, cardiac glycosides, anticoagulation therapy. So these are the medical management. Now the surgical management is cardiac transplantations. So number 2, hypertrophic cardiomegaly. In this asymmetric left ventricular hypertrophy without ventricular dilation, when the septum between two ventricles become enlarged and obstruct the blood flow from the left ventricle, and it is known as hypertrophic obstructive cardiomyopathy. So here is the diagram of normal heart and heart with left ventricular hypertrophy, A, B and C with dilated CM. Now what are the causes? Inherited causes because of gene mutation, aortic stenosis, genetic hypertension, and more common in men between 30 to 40 ages. Now what are the pathophysiology of hypertrophic cardiomyopathy? Thickened intraventricular septums and ventricular wall, then ventricular hypertrophy, then diastolic dysfunction, then impaired ventricular filling and obstruction to decreased outflow, then last decreased cardiac output. Now, what are the features? Exertional dyspnea, shortness of breath during exercises, decreased cardiac output, fatigue, angina, syncope, hypertension. Moving towards its diagnosis tests. Number one, history and physical examination. Number two, transthoracic echocardiogram. In this test, a device transducer is pressed firmly against your skin. As you can see in these pictures, so the transducer aims an ultrasound beam through your chest to your heart, producing moving images of working of the heart. Number two, ECG electrocardiogram. Wires electrodes attached to adhesive pads on your skin measures electrical impulses from your heart. An ECG can detect enlarged chamber of your heart and abnormal heart rhythm. Number 3, cardiac MRI. A cardiac MRI uses magnetic fields and radio waves to create images of your heart. Now moving towards next, medical management. Number one, beta energetic blockers, for example atenolol, calcium channel blockers, for example verapamil, and number third, antidysrhythmic drugs, for example amiodarone. Now moving towards next, surgical management. Number one, septal myectomy. It is an open heart surgical procedure in which the surgeon removes the part of thickened overgrown septum between the ventricles. Number two, septal ablation. It is a procedure a small portion of the thickened heart muscle is destroyed by injection alcohol through a long thin tube into the artery, supplying blood to that area. Now moving toward the last type of cardiomyopathy is restricted cardiomyopathy. Diseases of heart muscle that impair diastolic filling with stretch and systolic function remains uninfected is called restricted cardiomyopathy. Now, what are the etiology of restricted cardiomyopathy? Is number one, unknown etiology. Number two, myocardial fibrosis, endocardial fibrosis, sarcoidosis, and radiation to thorax. Pathophysiology. Number one, etiological factor. Then stiffness of ventricular with wall, loss of ventricular compliance. Number three, ventricles become resistant to filling. At last, decrease cardiac output. Now, the clinical features of restricted cardiomyopathy is number one, fatigue, exercise intolerance, dyspnea, orthopnea, syncope, palpitation, peripheral edema, jugular venous distension. So these are the clinical features of restricted cardiomyopathy. Now moving toward the diagnostic test of restricted cardiomyopathy is number one, chest X-ray shows cardiomegaly. Number two, ECG shows tachycardia. Echocardiography for visualization of left ventricle. Number 4, CT scan and MRI scan. So now moving toward its medical management, beta adrenergic blockers, calcium channel blockers, steroids, and antidysrhythmic drugs. Now moving towards its surgical management, a heart transplantation may be considered if the heart function is very poor and the symptoms are severe. So we can go with surgical procedures. Now moving towards surgical nursing management, instruct the patient to take all medicine on prescribed time. Number 2, encourage to use low sodium diet. Number 3, instruct to drink more water. Instruct the patient to maintain body weight. Teach the patient to balance activity and rest. Instruct the patient to avoid vigorous activities and exercises. Encourage to perform stress reduction activities. Teach about breathing and coughing exercises. Suggest a family member to learn about CPR. So this is the short lecture of cardiomyopathy. I hope guys you like this video. Then please share this video to your medical friend. Thanks for watching.